Imagine looking down at your hand right now and seeing um, just a perfectly straight, pitch black line right across your ring finger.
Mm-hmm.
And on one side of that line, you have healthy, warm, pink skin. But on the other side, it's completely mummified tissue.
Yeah, it's a terrifying image, honestly.
Right. And today, we are going on a deep dive into the bizarre medical detective work required when your fingers literally start dying. Because, I mean, when we hear the word gangrene, there's a very specific image that usually pops into our heads, right?
Oh, absolutely. The classic clinical presentation most people picture is an older patient, maybe managing advanced diabetes, dealing with a severe complication in their foot.
Yeah, the diabetic foot.
Exactly.
Yeah.
Lower limb ischemia. It's driven by decades of plaque building up in the arteries, and it's something medical students are trained to look out for on day one because, well, it is incredibly common.
But gangrene of the upper limb, specifically the hand of the fingers, is just an entirely different beast.
It really is.
It operates on a completely different set of rules.
Yeah.
So we're going to explore the surprising anatomy of the arm, the frankly mind-boggling ways blood flow can get choked off to our fingertips, and the intense detective work doctors have to perform.
Because in these scenarios, a surgeon isn't just trying to save a hand, they are often trying to save a life.
Wow, high stakes.
Very high. The stakes are remarkably high, precisely because the arm is built fundamentally differently than the leg.
Right.
If a patient presents with a black, dying finger, it almost always means something has gone systematically or catastrophically wrong somewhere else in the body.
So it's a massive, blaring red flag.
Exactly. It's a symptom of a much larger issue. So our goal today is to unpack that entire spectrum of tissue death, moving all the way from the microscopic cellular level right up to the surgical suite.
Okay, let's unpack this. Because before we can get into the wild reasons why fingers die, we have to define what that tissue death actually looks like.
Right, because not all gangrene is created equal.
Exactly. There are vastly different types, and they require completely different medical responses. So what are we looking at here?
Well, the word itself gives us a clue. It comes from the Greek gangrena, which basically translates to a putrefying sore.
Yikes.
Yeah, not pretty. Clinically, gangrene is defined as necrosis, which is the death of cells in tissue combined with putrefaction.
Okay.
But the most critical distinction a surgeon has to make the second they walk into the room is whether they are looking at dry gangrene or wet gangrene.
And the distinction between those two is honestly a bit macabre. Let's start with dry gangrene. What is happening mechanically to the limb to cause this?
So dry gangrene happens when the arterial blood supply, the fresh blood bringing oxygen into the hand, is cut off very gradually.
Okay, slowly starving.
Right. But crucially, the venous drainage, the blood flowing away from the tissue that remains intact.
Oh, I see.
Yeah, so because the fluid can leave but new fluid can't arrive, the tissue just slowly dries out. It desiccates.
It essentially mummifies.
It turns brown, then pitch black, and forms a very distinct boundary line between the living tissue and the dead tissue.
I want to use an analogy here to visualize this for you. Dry gangrene is basically like a medieval castle under siege, where the attacking army just starves the inhabitants out.
I like that analogy.
Yeah, no new supplies get in, but the moat drains away.
Yeah.
Eventually, everything inside just dries up and stops moving.
That is a highly accurate way to visualize the cellular environment. And it actually explains a fact that always surprises people.
Which is?
Dry gangrene is actually considered relatively safe in a clinical setting.
Wait, really? Which sounds completely counterintuitive when we were talking about a dead black finger still attached to someone's body. How can that be safe?
Well, the safety comes from the desiccation. Because the ischemia, the lack of blood, is so absolute, the tissue becomes totally dehydrated.
And bacteria need water to live.
Exactly. Without moisture, bacteria simply cannot survive or multiply. The environment is too harsh, so the tissue is essentially sterile. Yeah, it doesn't spread rapidly. A surgeon's instinct with dry gangrene is actually to hold off on operating. You just wait.
You wait for it to fall off.
Kind of, yeah.
Right.
You let that line of demarcation fully mature. Eventually, the body will literally auto-amputate the dead tissue on its own, or the surgeon makes a very clean cut once the boundary is totally stable.
Okay, so if dry gangrene is a castle under a slow, starving siege, wet gangrene is like the castle walls being violently breached.
Right.
The invaders flood in, multiply, and spill out into the surrounding countryside, basically burning everything down.
The breach is exactly the problem here. Wet gangrene occurs when you have a venous blockage, or like a sudden mix of arterial and venous compromise.
So the fluid is stuck.
Yes, the fluid cannot escape. It gets trapped
Yeah.
in that wet, swollen, fluid-filled environment. What we call edematous tissue, anaerobic bacteria absolutely thrive.
Because it's a stagnant swamp.
Exactly. They multiply at astonishing rates. The patient develops aggressive blistering, severe swelling, and a truly foul smell.
Because the bacteria are basically eating the tissue.
Right. They are actively producing sulfur compounds as they consume the dead tissue.
Jeez. But if the bacteria are trapped in that fluid, what keeps them from just migrating up the arm?
Nothing.
Oh.
That is the terrifying part. They do migrate, and that localized infection quickly becomes systemic sepsis.
Which is deadly.
Extremely. Wet gangrene is a life or death surgical emergency. There is no waiting around for a clean line of demarcation to form because that line is blurry and constantly moving up the limb.
Right, so the surgeon has to act fast.
Immediate debridement. They have to aggressively cut away the dead and infected tissue and often amputate. If they don't, the infection will climb the arm and kill the patient within days or even hours.
That is wild.
Yeah.
And the most extreme version of this has to be gas gangrene.
Gas gangrene is a nightmare scenario. It's typically caused by the bacteria Clostridium perfringens.
And these bacteria actually produce neurotoxins and tissue-destroying enzymes at an alarming speed, right?
Incredibly fast.
But the most visually shocking part is that they release gas as a biological byproduct of their feasting.
Yes, to the point where doctors can actually feel something called crepitus.
What does that feel like?
If you press on the patient's skin, you feel a distinct crackling sensation. It's almost like bubble wrap underneath the surface.
Ugh, that's horrifying.
It really is. You can take an X-ray and see literal pockets of gas bubbles forming inside the muscle tissue. The destruction is incredibly rapid.
Okay, there's also a really sneaky third type of tissue death called venous gangrene.
Right.
This happens when there's massive blood clotting exclusively in the veins. It creates such extreme back pressure that it eventually blocks the fresh arterial blood from coming in. But what makes it so tricky to diagnose?
Well, it gets missed because initially the arterial pressure is still strong enough to push blood into the wrist.
Oh, so the doctor feels a pulse.
Exactly. A doctor might feel a totally normal bounding pulse at the radial artery. They think the blood flow is fine.
But it's not.
Right. Downstream, at the capillary level, the pressure is so backed up that oxygen exchange completely stops. In the upper limb, venous gangrene is very rare, but highly lethal. It is almost always a pre-terminal event.
Meaning the patient is already very sick.
Yeah, it's associated with severe advanced cancer where the blood has become hypercoagulable or with catastrophic heart failure.
Man. So because wet gangrene moves so violently through the veins, it forces us to look at the arm's actual plumbing system.
We have to.
Just to understand why this whole process doesn't happen more often. I mean, we bang our hands on doors, we sleep on our arms until they go completely numb, we expose them to freezing cold. Why aren't our fingers constantly dying?
The answer lies in the human upper extremity's remarkably rich collateral circulation.
The backup plumbing.
Exactly. Over millions of years of evolution, we developed a system built on redundancy. Think about all the blood vessels branching off the axillary artery deep in your armpit.
Right.
And around the elbow, there is a massive, complex network of interconnected vessels. We call them anastomoses.
That's a fun word. Anastomoses.
Yeah, they bridge the radial artery, the ulnar artery, and the interosseous artery, which runs right between the two bones of your forearm.
It's like a brilliantly designed city traffic grid.
Perfect analogy.
Right. If there's a massive multi-car pileup on Main Street, traffic doesn't just stop forever. It detours down a dozen different side streets, alleys, and parallel avenues, and everyone still gets to their destination.
Exactly.
But how does the body actually build those detours? Does it happen instantly?
Well, there are pre-existing microscopic connections, but if a blockage happens slowly over time, the body actually responds to the lack of oxygen by expanding those tiny side streets.
It remodels them.
It remodels the blood vessels to carry more volume. It's so robust that even if the main brachial artery in your bicep gets completely severed or blocked, the arm can often survive perfectly fine.
Amazing.
The blood simply reroutes around the elbow through that collateral grid.
There is a fatal flaw in this design.
There is.
The fingers are not part of that city grid. The digital arteries that feed our fingers are what doctors call end arteries.
Right. Each finger gets exactly 2 digital arteries, running parallel down the medial and lateral sides.
Just two.
Just 2. There are no interconnected side streets between them. They're the end of the line.
Dead end cul-de-sacs.
Exactly. If both of those tiny arteries get blocked, there is no backup plumbing to save the day. The tissue simply starves.
Which brings us to a major diagnostic difference between the legs and the arms. If an older patient has gangrene in their foot, it's usually from atherosclerosis. Plaque slowly building up on the vessel walls over decades. But upper limb acute ischemia is very rarely caused by plaque.
Very rare. Yeah.
It's usually embolic, meaning a rogue clot formed somewhere else in the body, broke off, traveled like a missile through the bloodstream, and crashed right into those tiny dead-end streets in the fingers.
If we connect this to the bigger picture, this anatomic quirk completely changes the diagnostic mindset of a vascular surgeon.
How so?
When they see a gangrenous finger, they know the blockage isn't just an isolated event localized to the hand. The hand is just the victim.
The alarm bell.
Yes. The black finger is a loud, blaring alarm bell for a distant, hidden problem somewhere else in the vascular system.
So when a surgeon is trying to figure out what caused the blockage, the very first thing they look for is a massive visual clue, right? Is this happening in one arm or both?
Exactly. Unilateral versus bilateral.
Let's start with unilateral. One arm. A patient comes in with a sudden, cold, pale, and pulseless hand on just the left side. What is the prime suspect?
An embolism is at the top of the list. A blood clot has traveled from a proximal source, and that source is usually the heart.
Like from a heart arrhythmia.
Yeah, we see this frequently in patients with atrial fibrillation. The heart's upper chambers beat in an irregular, chaotic rhythm, which allows blood to pool and stagnate in the corners.
And stagnant blood clots.
Right. Eventually, the heart pumps normally for a beat, dislodges that clot, and shoots it down the arm. It could also be a clot from the left ventricle after a heart attack, or even bacterial clumps breaking off from an infected heart valve, which is a condition known as endocarditis.
Now, doctors actually look for tiny red lines under the patient's fingernails called splinter hemorrhages to diagnose this. But why under the nails specifically? How does a heart infection end up painting red stripes on your fingertips?
Oh, the mechanism behind that is fascinating. The capillary beds directly under our fingernails are incredibly narrow. They are the ultimate biological filter at the very end of the circulatory line. So when a tiny piece of an infected heart valve, like a microscopic clump of bacteria and fibrin, breaks off, it sails easily through the larger arteries of the chest and arm.
Because they're wide.
Right, but it physically gets wedged in those microscopic end capillaries under the nail. It ruptures the tiny vessel, creating a visible, splinter-like red streak of trapped blood.
Wow, that is incredible detective work. But what if the gangrene is bilateral? What if a patient comes in with black fingertips on both hands, or maybe a hand and a foot simultaneously?
That shifts the investigation entirely. Bilateral presentation strongly suggests a systemic disease.
Like something in the blood itself.
Yes, something circulating in the blood or immune system affecting the small vessels everywhere in the body at once. The most notorious culprit, particularly in young patients, is Buerger's disease.
Also known as thromboangiitis obliterans.
Exactly.
Buerger's disease. First described by Felix von Wienerwerder in 1879, but named after Leo Buerger, who published massive pathological findings on amputated limbs in 1908.
That's the one.
And it primarily targets young men, specifically heavy smokers, with huge prevalence in Asia, the Middle East, and Eastern Europe.
Yes, the demographic is very specific.
And it creates a very specific, beautiful, but terrifying pattern on an angiogram.
Right?
Which is that imaging test where they inject dye into the blood vessels.
The corkscrew collaterals.
Yes. The tiny vessels literally twist and spiral like a corkscrew, trying to desperately bypass the blockages.
And the progression is devastating. The patient will often start with severe cramping pain in the arch of their foot when walking.
Just from lack of blood flow.
Yeah. Then the pain happens even at rest. Then painful ulcers form on the tips of the toes and fingers. And finally, frank gangrene sets in.
Here's where it gets really interesting, though. We established that Buerger's isn't regular plaque buildup. It's not atherosclerosis.
No, it's not.
So what exactly is the tobacco doing to the inside of the blood vessels to cause this?
This raises an important question about pathology and autoimmune triggers. Buerger's is fundamentally an inflammatory vasculitis.
Meaning inflammation of the vessels.
Right. When pathologists slice these amputated vessels open and look under a microscope, they don't see yellow cholesterol plaque. They see a highly cellular inflammatory thrombus.
What does that mean?
It is essentially a thick sludge of inflamed white blood cells, immune cells, and clotting proteins completely clogging the vessel
But why does it only happen in the small arteries of the hands and feet?
because of the endothelium.
Oh.
Crucially, the actual wall of the blood vessel, the internal elastic membrane, remains structurally intact.
Oh, I see.
The chemicals in tobacco trigger a massive localized autoimmune response where the body's immune system attacks the lining of its own small and medium-sized arteries. It cooks up this cellular sludge exclusively in the distal extremities.
And the treatment for this is shockingly absolute. 100% complete tobacco cessation. Not cutting back, not switching to a patch.
I cannot emphasize this enough. Even 1 or 2 cigarettes a day keeps the autoimmune disease intensely active.
Wow.
Even nicotine replacement therapy like gum or patches keeps it active. If the patient does not stop entirely, no surgery can save them.
Because it's a systemic reaction.
Exactly. The disease is too far distal, occurring in vessels way too small to bypass. They will lose digits, then hands, then feet. It is a true Berger's ultimatum.
So we've covered heavy smokers, and we've covered older patients with heart arrhythmias throwing clots. But what if our patient is a totally healthy 40-year-old carpenter?
Right.
No smoking, perfect heart, no systemic diseases. Sometimes the threat doesn't come from inside the blood at all, it comes from the outside world.
Yeah, one of the most unique occupational hazards we see in vascular medicine is called hypothenar hammer syndrome.
Okay, if you've ever used the heel of your palm to bang a stubborn piece of IKEA furniture into place, you've actually been participating in the exact mechanism that causes this.
It's true. The anatomy here is very vulnerable. The ulnar artery runs right through the fleshy part of your palm, very close to a small hard bone called the hamate.
Right.
When you repeatedly smash the palm of your hand against a hard surface, like a mechanic banging a hubcap or a carpenter forcing joints together, you are physically compressing that artery directly against the hamate bone.
You are literally hammering your own blood supply.
Over time, this repeated blunt trauma shreds the delicate inside lining of the artery wall. The vessel weakens and can form an aneurysm, which is a localized ballooning of the artery.
And clots form in that balloon.
Yes. Inside that balloon, blood swirls and clots. Those microclots then shoot downstream into the dead-end digital arteries of the ring and pinky fingers, causing focal gangrene.
And it's not just physical hammering either.
No.
People who use intensely vibrating tools like jackhammers or heavy chainsaws can suffer similar vibrational trauma to the digital arteries over years of use, causing them to permanently spasm and close.
Very true.
But there is another external force we have to talk about, and that is the doctors themselves. Iatrogenic gangrene, meaning gangrene caused by medical treatment.
It is a hard truth in medicine. Many of the interventions we use to monitor or save lives can inadvertently put limbs at severe risk.
Like what?
Well, for instance, in an intensive care unit, doctors frequently place an arterial line, a rigid plastic catheter, directly into the radial artery in the wrist.
To monitor blood pressure.
Yes, to constantly monitor blood pressure beat by beat, or to draw arterial blood gases. The presence of that foreign plastic can irritate the vessel and cause a massive clot, completely blocking the radial artery.
There's also something called Steele syndrome in dialysis patients.
Oh, yeah.
Patients with failing kidneys have an artificial connection surgically created between an artery and a vein in their arm to handle the massive high-pressure flow of a dialysis machine.
The fistula.
Right. But sometimes that high-flow fistula literally steals the blood away from the rest of the arm. The fresh arterial blood takes the path of least resistance, rushing through the giant artificial loop back to the heart, completely bypassing and starving the fingers downstream until they turn black.
Which is precisely why preventive clinical tests are so vital before we ever insert a line or create a fistula.
Yes. I want you, listening right now, to try a quick mental exercise. Or actually do it if you aren't driving and your hands are free.
This is a great test.
It's called the Allen test, and it's how doctors prevent that iatrogenic gangrene before they ever stick a needle in your wrist. I want you to imagine making a super tight fist, clenching as hard as you can to squeeze all the blood out of your hand. Now take your other hand and press down hard on both sides of your clenched wrist, on the thumb side, which is the radial artery, and the pinky side, which is the ulnar artery. You are artificially cutting off all the blood to your hand.
If you opened your fist right at that moment, your palm would be ghost white, completely blanched.
Exactly.
Yeah.
Now imagine lifting your finger off just the pinky side, releasing the ulnar artery. But you keep the thumb side blocked. Within just a few seconds, Your whole hand should flush pink again.
The blood rushes back.
Right. That immediate rush of color proves that your body's backup plumbing works perfectly. It proves that even if a doctor accidentally destroys your radial artery with an ICU catheter, your ulnar artery can handle the entire city traffic grid on its own and keep your fingers alive.
It's a remarkably simple, elegant bedside test. It takes 2 minutes, requires zero equipment, and saves limbs every single day.
So we now have this incredibly complex suspect list.
We do.
We've got the suffocating siege of dry gangrene, the infected breaches of wet gangrene, rogue clots from vibrating heart valves, carpenters hammering their own arteries, dialysis fistulas stealing blood, and tobacco triggering an autoimmune sludge.
It's a lot to consider.
How on earth does a surgeon take all these clues, make a final diagnosis, and physically fix the problem before time runs out?
The diagnostic flow has to be highly systematic. They will draw blood for autoimmune panels to look for connective tissue diseases. A prime example is scleroderma, or its limited variant known as CREST syndrome.
CREST stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. That is quite the mouthful.
It is. But the key symptom for our purposes is sclerodactyly.
What is that?
This is an extreme, progressive fibrosis and tightening of the skin on the fingers. The skin becomes so tight and thick that it acts like a tourniquet, eventually crushing the tiny digital arteries underneath.
Crushed from the outside in.
Exactly. To map out exactly where a blockage like that or a clot is located, surgeons use Doppler ultrasounds to listen to the pitch of the blood flow and CT angiograms to create a 3D map of the vascular system.
Okay, so once they find the exact location of the blockage, how do they physically get it out? If it's a heart clot sitting in the arm, the standard procedure is an embolectomy using a Fogarty balloon catheter. How does that actually work?
It is a delicate mechanical sweep. The surgeon threads a tiny flexible tube with a deflated balloon at the tip into the artery.
Okay.
They push it right past the clot. Once it's past the blockage, they inflate the tiny balloon so it touches the artery walls, and then they slowly drag the balloon backward.
Oh, almost like a little snowplow.
Exactly like a snowplow. It sweeps the clot right out of the vessel through the surgical incision.
And what about the carpenter with the crushed artery?
For our carpenter with the crushed hamate artery, the fix is different. They might surgically cut out the damaged ballooning section of the artery in the palm entirely and stitch in a bypass using a healthy, expendable vein harvested from the patient's own leg.
Wow. But sometimes, despite all the bypasses and balloons, the tissue is simply dead. Amputation becomes the only path forward.
Unfortunately, yes.
And the surgical techs have very strict rules for this. For dry gangrene, as we discussed, they wait for demarcation. But when they finally make the cut, there is one universal rule. The thumb is king.
The thumb is king. The human thumb accounts for roughly 40% of all hand function.
40%.
Yes. Without it, the ability to pinch, grasp, or hold objects is severely compromised. A surgeon will do everything in their power, try every medical therapy, every bypass trick available to preserve even a fraction of a centimeter of the thumb.
That makes sense.
They will amputate other fingers much more readily just to save the thumb.
Which brings us to the core philosophy of what it means to be a vascular surgeon.
What's fascinating here is that the discipline explicitly frames the surgeon not merely as a technician who cuts away dead tissue, but as a systemic detective.
Right, because the finger is just the symptom.
Exactly. Anyone with a scalpel can cut off a black finger. But if you cut off that finger without identifying the underlying atrial fibrillation throwing clots, or the Berger's disease fueled by a secret smoking habit, or the undiagnosed autoimmune disorder causing the skin to tighten,
You haven't actually fixed anything.
you haven't. That patient will just return a year later to lose another finger, a foot, or their life.
We've gone on quite a journey today. From understanding why a dry, mummified finger might actually be safer than a wet, infected one, to marveling at the arm's collateral plumbing grid that leaves the fingers as vulnerable cul-de-sacs.
It's a complex system.
We've tracked the diagnostic clues that separate a heart embolism from an occupational hazard like Hypothenar-Hammer syndrome, and seen how crucial that detective work really is.
Before we wrap up, there is one final tantalizing detail regarding emerging therapies.
Oh.
For patients with end-stage Berger's disease, where the vessels are simply too microscopic to bypass and amputation seems inevitable, researchers are actively testing therapeutic angiogenesis and stem cell therapy.
So angiogenesis,
Yeah,
literally growing new blood vessels from scratch.
exactly. Doctors are taking growth factors like vascular endothelial growth factor or autologous bone marrow stem cells, cells taken directly from the patient's own marrow, and injecting them directly into the ischemic, dying tissue of the hand or leg.
And what does that do?
The goal is to stimulate the body's natural regenerative systems to build a brand new microvascular network, effectively creating its own organic bypass around the dead zones.
So what does this all mean for the future of medicine? I want you to think about this. If we can actually teach the human body to perform its own bioplumbing, to spontaneously grow brand new vascular pathways to rescue a dying finger, where does that end?
It's a profound question.
Could injecting these exact same stem cells and growth factors eventually be the key to bypassing dead zones in the heart after a massive heart attack? Could it revascularize the brain after a severe stroke?
The potential is staggering.
Could this be the secret to literally reversing the aging process in our major organs by constantly refreshing their blood supply from the inside out?
It fundamentally changes our entire relationship with tissue death. We move from just managing decay and amputating the losses to active, deliberate regeneration.
It's incredible. We started today talking about the stark, clean, binary precision of an X-ray showing a broken bone, broken or not broken.
Right.
But the human vascular system, with its detours, its complex adaptations, its capacity to be poisoned by smoke or crushed by a hammer, and now perhaps its ability to grow anew on command. It is anything but binary. It is dynamic, highly complex, and deeply resilient. Thank you for taking this deep dive with us today. Keep questioning the obvious, keep looking past the surface symptoms, and above all, stay intensely curious.